Hey guys, this week we're going to be discussing neuromotor disorders and the types of practice models used to guide evaluation and intervention of neuromotor disorders, as well as touching on the developmental theory of mobility. I'm going to give you a heads up that as I record this, one of my dogs is sleeping underneath my feet. I keep kicking her away, but she keeps coming back, so I apologize in advance if you can hear a beagle snoring in the background. I think we'll make do though. The objectives for this presentation are that you will be able to describe the clinical presentation of CP and how this condition impacts occupational performance in children and youth, understand the practice models commonly used to address neuromotor disorders, and discuss the importance of early mobility in early child development. Hey guys, we're going to be discussing neuromotor disorders this week and the types of practice models used to guide evaluation and intervention for neuromotor disorders. In addition, we're going to be touching on the developmental theory of mobility. The objectives for this presentation is that you'll be able to describe the clinical presentation of CP and how this condition impacts occupational performance in children and youth, understand the practice models commonly used to address neuromotor disorders, and be able to discuss the importance of early mobility in early childhood development. The term neuromotor disorders describes a group of disorders in which there is a dysfunction in the nerves and neurons that transmit information from the brain to the body. Types of neuromotor disorders include cerebral palsy, muscular dystrophy, traumatic brain injuries, seizures, and spina bifida. The most prevalent cause of neuromotor dysfunction in children is cerebral palsy, with a prevalence of 1 in every 500 births. The term cerebral palsy refers to a group of developmental motor disorders caused by a non-progressive lesion or disorder of the brain. Associated damage to one or more areas of the brain can lead to paralysis, spasticity in the muscles, or abnormal control of movement and postures. The assigned reading in Case Smith and O'Brien this week shares some common risk factors for CP, so be sure to read that. At the bottom of the slide here, you'll see a link to a video, which I'd like you to view so you can understand the different types of movement patterns you may see in individuals with CP. So go ahead and pause this presentation and go watch that video now. Welcome back. Now that you have a picture in your mind of the different ways and different types of movement that you can see in children with CP, let's discuss the different types of CP. In spastic CP, the motor area or cerebral cortex is impacted, resulting in poor control of voluntary movement and limited ability to regulate force. Children can have spastic hemiplegia, meaning one side of the body is impacted, diplegia, meaning that the legs are more affected than the arms, or quadriplegia, meaning that all 4 extremities are involved. In dyskinetic CP, the basal ganglia is impacted, which controls coordination of movement. Children with dyskinesia have excessive and abnormal movements. There are 2 types of dyskinetic CP called apatoid and dystonic. With dyskinetic apatoid CP, you will see slow, writhing, and involuntary movements combined with abrupt, irregular, and jerky movements. With dystonic CP, you see twisted postures that are usually triggered by movement. And the last type of CP is ataxic CP, which impacts the cerebellum. This type of CP is characterized by poor balance and coordination. These children exhibit shifts in muscle tone, often throughout all 4 of their extremities. They are often more successful with voluntary movement, but can appear clumsy. The gross motor classification system is a 5-level system used to describe gross motor function in children with CP. When a child is diagnosed with a type of CP, such as spastic quadriplegic CP, that diagnosis remains the same throughout the lifespan. However, the functional implications of that diagnosis can change over time, especially in response to early interventions. This system allows therapists to assign a level that best describes the child's current abilities and limitations with self-initiated movements. This is important to know because you may be asked as an OT to assign a level to a child you are seeing, which allows all of those working with the child to understand what the child's current level of functioning is, Or you may receive a child on your caseload that already has a level assigned to them, and that can give you a good picture of where the child is at and then guide your intervention moving forward. So this picture here describes the different levels in the gross motor function classification system. You can see a child with level 5 is severely limited in their mobility and requires special equipment and aids for their mobility, whereas a child with level 1 walks without really any restrictions but may have limitations for more complex movements such as running and jumping. The manual ability classification system is used to describe how a child with CP uses their hands to manipulate objects during everyday activities. Like the gross motor classification system, the therapist can assign a level to describe the child's hand skills, which can change over time with interventions. Now, think back to our discussion a few weeks ago about typical development. What is included with fine motor development? Is it just the hands? What does this mean for people with CP? Also consider how fine motor difficulties may impact speech. Let's shift now to talking about let's shift to talking about functional impairments associated with CP. Primary impairments refer to those that are immediate and direct. Let me back up. Primary impairments refer to those that are an immediate and direct result of the cortical lesion in the brain, causing the progression of the child's motor development to change. Examples of primary impairments that you see listed here are muscle weakness or hypotonicity, muscle tightness or hypertonicity, spasticity, involuntary movements, weakness of the eye muscles, abnormal tone and facial musculature, and impaired sensation. These primary impairments can then lead to secondary impairments, which can impact function. The following are examples of secondary impairments commonly seen in children with CP. So things like contractures, poor or unsteady gait and mobility, impaired vision, hearing, or speech, difficulty with bowel and bladder control, intellectual or learning disabilities, problems with breathing, problems with skin integrity, and difficulty with feeding, eating, and swallowing. So now I'll share several pictures of individuals with CP so you can continue to get an idea of their posturing and the different types of equipment they may use. This child is in some type of seat or wheelchair that has chest support to help with upright posture. The markers are taped to his chest strap, so he just needs to move his body to scribble on the paper rather than control the movements of his hand to color. Here you can see a walker with chest support, and it also appears, he also appears to be wearing some sort of splint to help keep his elbows extended. This child is not in any type of specialized seat or wheelchair, and you can see his atypical posturing in his hands and legs, as well as the asymmetry of his mouth. So you can see that this child would definitely benefit from an evaluation by an OT or PT to determine the best kind of positioning equipment to help with his functioning. Here's a child using forearm-based crutches. So this week's assigned chapter in Case Smith and O'Brien discussed some common practice models used to guide the evaluation and treatment of children with CP and other neuromotor disorders. Because children with CP have difficulty with movement against gravity and postural control, motor control and motor learning concepts are frequently implemented by therapists working in this population. And we're going to be talking in detail about motor learning and motor control next week. Dynamic systems theory is also discussed in the chapter, which states that movement is a result of multi-dimensional systems working in coordination to influence movement. And the assigned chapter this week provides some nice examples of what that entails with children with CP. One that was not mentioned in the chapter but is often used with children with CP and neuromotor disorders is NDT, which is another assigned reading this week in the Kramer and Hinojosa text. So make sure you read that and review that, and we will be discussing that briefly at the beginning of class next week. The developmental theory of mobility recognizes that physical and psychological developments are interrelated and that early experiences impact subsequent development and behavior. Developmental theorists believe that early motor interactions allow infants and toddlers to learn about their world, and early motor development that occurs during the first 3 years of life serves as the vehicle for future learning and socialization. Jean Piaget, a well-known developmental theorist, believed that a child's self-produced movement serves as a building block for further development of knowledge and skills. With that perspective in mind, OTs can consider how learning opportunities may be hindered for children with physical disabilities, including neuromotor disorders. Because children with neuromotor disorders such as CP often lack self-initiated movement, they don't have the opportunity to experience the same types of sensory motor and developmental activities as typically developing peers their age, which can have a long-lasting influence on the child's development. Chapter 20 assigned to this week discusses how infants born with significant motor impairments may develop learned helplessness when they begin to lose interest in their world because of their motor disability. Therefore, it's important for therapists working with children with motor disabilities to provide interventions that can establish early mobility opportunities. And, I showed a couple pictures a few slides back of some common types of positioning devices and equipment, and here is a few more as well. And it's important to know that new aids and devices are constantly coming out, so if you're working in a population of children where there's a lot of mobility difficulties, it will be really important for you to stay up to date on the most currently available equipment. But here you can again see some forearm crutches, a reverse walker, a pediatric quadriplegic cane, bilateral straight canes, the one in the middle with the little girl with the glasses, that's a gait trainer. In the bottom right, you can see some corner chairs that are used for positioning, and then that little girl with the pink bow at the top is in a standing frame that can support some weight bearing through her lower extremities. Here you can see some different types of wheelchairs and strollers that support proper posturing, as well as some different types of splinting and bracing that may be used with children with neuromotor disorders. So that wraps up the presentation on neuromotor disorders. I just want to direct you again to the online activities for this week, which include a brief discussion question and short reflection paper regarding 2 different case studies, as well as completing the practice model worksheet for NDT. And these are all due on Sunday, September 10th. As always, be sure to email me with any questions you may have about this presentation or any of the assignments for this week. Thank you.